Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Bayer.
Hi, everyone, and welcome back to our preventive cardiology podcast entitled The Cardiac Risk Continuum, where our focus has been to know your risk and act early, particularly with an imaging focus on prevention. So, in this 6-part series, we've covered a number of topics. In episode 1, we talked about lifestyle therapy and primordial prevention. In episode 2, we talked about the coronary artery calcium score and where that plays a role in risk prediction. In episode 3, we talked about the carotid ultrasound test and how that can see carotid plaque and also contribute to risk assessment. In this episode 4 today, we're going to talk about where cardiovascular preventive medications play a role in this story of preventive cardiology. I'm Dr. Michael Blaha from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And with me today, it's my great pleasure to have on Dr. Martha Galati, who's a preventive cardiologist and women's cardiovascular disease specialist at Houston Methodist. So, Martha, thank you so much for joining us today on the podcast.
Thank you for having me, Michael. I'm happy to be here.
Okay, I'm so excited for this conversation. We've talked about risk assessment and imaging, and now it's time to talk about when and where and how we use cardiovascular medications, preventive medications, to manage risk in certain patients in preventive cardiology. Of course, we think about lifestyle and we think about medications always in all of our patients, but of course, we lean more towards one or the other based on the risk of the patient. So, give me a quick snapshot of how you view lifestyle and pharmacologic interventions in preventive cardiology. How do you think about when to prioritize one or the other?
Yeah, well, I prioritize lifestyle in everyone, especially when we have patients that we identify as high risk or those obviously who already have cardiovascular disease, who are technically high risk by definition. I think at that point, of course, lifestyle will always be part of what we're recommending, but we know they're going to need more than that. It's hard because I think sometimes there's patients who are identified as high risk and always say, well, can I try lifestyle first? I'm not opposed to them initiating all the important lifestyle recommendations that we make. Yes, do the lifestyle. If you want to see those numbers improve before we start medication, fine, we want to work with you, but you are still going to need medication. Lifestyle is part of this treatment, but it's always additive.
Yeah, I think that's a really great point. Really, it's about both, of course. And of course, we just need to know the patient's risk. So, of course, in this series, we've talked quite a bit about risk, how we can use a calculator like the Prevent Risk Calculator, or maybe as a companion tool, imaging tests to look for atherosclerosis. So, when would you say patients are sufficiently high risk that we're going to go right in and talk about medications in the primary prevention space right away?
Well, in the primary prevention space, I mean, certainly now that we're using the prevent risk score and the numbers have changed, particularly the 10-year risk. By that shift by itself, we know those people that classify as high risk. We're very fortunate that most of our clinics are filled with people who don't yet have active cardiovascular disease. But how do we keep them there? So I think these tools also help us, though, beyond the prevent risk score. I really appreciate what the guideline writers included. Now, clear recommendations of looking for subclinical atherosclerosis. And it's particularly an emphasis on coronary artery calcification, using that in our clinical practice, and even within that, risk stratifying. So, meaning if you see already extensive coronary calcium with a calcium score greater than 1,000, and that's a high risk individual. And these are people that we're going to have different LDL goals. In fact, I think the guidelines said LDL goal under 55. That's definitely high risk group. But even the people with coronary calcium above 300, again, this is a group that, yes, lifestyle is important, but I'm still going to recommend initiation of statin therapy. And the LDL goal is recommended to at least be under 70. You could go lower, depending on other risk enhancers. I think the other part also that was included in the guidelines, though, was also incidental coronary calcium that's identified on other imaging, other CTs that people have for a variety of different reasons. And when we have that information, those are people that we are going to want to treat initially with statin therapy or other lipid lowering therapy with very specific goals for our patients. So to me, those are the high risk groups. Our patients with diabetes are a unique group as well. Just by having diabetes alone, there is a higher risk of cardiovascular disease, and of course, earlier better because again, we know the vascular damage um, can be happening when they're young. And then we are seeing younger and younger people, not just obviously type 1 diabetes, but type 2 diabetes. We're even seeing it in young children now way more frequently than we ever saw it before. Lifestyle, yes, always, 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 yes. Medical therapy, though, should be discussed up front, even if the person wants to see what they can do with their dietary changes or any other additional lifestyle changes. There should be an upfront discussion that we know that you'll need drug therapy because of some of the other benefits from these drug therapies.
Some great discussion there. Great points you made about the guidelines, which do give that class one recommendation for the prevent risk score, but also in many circumstances, the calcium score to determine risk, and have that conversation with patients that sometimes a combination of lifestyle and medical therapy is needed up front. And you brought up a really great point there about lipid lowering therapy. The new guidelines emphasize, of course, certain patients who need to start lipid lowering therapy right away, probably earlier maybe than we would have recommended in the past, and potentially with higher intensity now that we've set LDL goals again. And LDL goals, like you mentioned, particularly for patients with high calcium scores, lower than before. What do you think about lipid lowering therapy and primary prevention? And do you think this emphasis on lower, earlier, and potentially with combination therapy fits with your practice?
Yeah, I do. We can predict in advance where we need to get. So if somebody's LDL is already 160 and I want to get them under 70, we can do the math and predict how much statin therapy and something else we're going to need to get them to goal. We can predict how much LDL lowering we're going to get.
Mhm.
And y- we don't need to like titrate things up slowly and then add in something gradually because we know it's taking years to get people to their LDL goals. But from a primary prevention standpoint, you have somebody engaged at that moment. They're there, you're talking about it. You can explain to them from the statin alone, it's going to get this much LDL lowering. We might consider a statin and ezetimibe, or we might consider statin and this. I know people are always worried about the risk of side effects and they want to know which drug might cause the side effect. But these drugs that we have for lipid lowering are really well tolerated these days. I mean, we're in a
Mhm.
very different era. So I still think the titration mentality needs to end. And I do think we need to be thinking about combination therapies. Sometimes when you write it as a combination drug, that also helps a patient mentally, like, okay, I'm just taking one new drug. So I hope more people will start using combination therapies and be aware of the numerous options we have. I do think that also sometimes the reason we do it stepwise, though, has been coverage issues, and I think that has been a truth in the United States where we are definitely thinking, "Well, I can't get necessarily this drug approved until I
Mhm.
prove that I can't do it along with statin therapy." So our insurers also have to catch up with us, in terms of thinking how important it is.
Such a great point. Emphasize those key points there. You get your patient to goal with these new goals, particularly when the calcium score is elevated above 100, like you said, or above the 75th percentile. Get the LDL below 70, or when the calcium score is above 300, maybe, or certainly when it's above 1,000, get it below 55, and just calculate what you need. And of course, the foundation of the primary prevention discussion is lipid lowering therapy. But I want to shift to the other key decision that we make, and that's aspirin, right? Aspirin used to be more of a foundational therapy in primary prevention, but we realized that you have to be more careful about selecting patients or who are really going to get a net benefit from aspirin. So, Martha, where does aspirin fit in your practice for primary prevention?
Yeah, so I think this is probably one of the things that comes up every day in our clinic settings because, we historically said aspirin a day keeps your cardiologist away. And then we shifted and started saying, look, we're getting more bleeding. And we also had trials that showed us that the net benefit did not outweigh the risks of bleeding. And so we shifted completely. We said, okay, aspirin isn't needed from primary prevention. But again, here's the place where coronary calcium scores also help us with these decisions too. I definitely use aspirin if there's coronary calcium above 300. So I feel like that's a reasonable threshold where the benefit would outweigh any of the harm. But with any of these discussions, of course, it's talking to the individual and understanding their individual risks. If somebody's had other bleeding, that's important for us to consider at this current time, whether we give aspirin or not. It's always is the benefit going to outweigh the risk? I think another group that I always struggle with is with our patients with elevated LP little a.
Mhm.
Because again, a group that we say that LP little a also has potentially prothrombotic effects. And should everyone be on aspirin? Well, we don't have a trial supporting that. We have some observational data that suggests that people with very high LP little a may benefit from being on aspirin therapy. But again, that's a place where I look at other risk factors. I look at their coronary calcium score. I need to look at their history of bleeding, particularly. And then I think it's a discussion with the patient. This discussion I have almost on a daily basis.
That's so true. I think those are the groups that I'm thinking the most about aspirin: high calcium score, high carotid plaque if you're using that test, but high lipoprotein A as well, particularly when both of those are present. An imaging test for atherosclerosis and a high LP little a. And some modeling studies have suggested when the calcium score is at least above 100 or at least even higher than that, or when the carotid plaque burden is moderate or at least in two segments, and maybe that's where the tipping point is for the benefit of aspirin. Of course, we're all measuring lipoprotein A on everybody nowadays, class one recommendation. So use that information too for aspirin. But I want to shift to one other decision, of course, we're making every day, as well as antihypertensives, right? And I think I want to focus on the group that's the most challenging, which is let's call it the stage one hypertension in the new guidelines, right? The patients who have just a mildly elevated blood pressure. Maybe we have a single measurement in the clinic that's a little bit elevated. They say that at home, my blood pressure is maybe a little bit better. They're kind of in between. And I think the guidelines are pointing out nowadays to also using risk assessment in these patients too, and figure out who we're going to treat earlier, who we're going to treat more aggressively, and who we might not. So I want you to hear your perspective on these patients with stage one hypertension. We certainly don't want to miss this critical risk factor in our high risk patients.
Yeah, the high risk patients, once they're identified as high risk, every part of their cardiovascular risk factors becomes important because these are the things we can control to reduce the risk to having cardiovascular events. I mean, if we did a better job of treating lipids and hypertension, imagine the number of lives we could
Right.
save. If you're stage one, it is worthwhile trying lifestyle specifically for blood pressure lowering, especially when somebody has a lot of things that they potentially can change. And what the guidelines now recommend is you can give them 3 to 6 months to try to lower their blood pressure if they're in stage 1 hypertension, and then you make a follow-up so that you have a concrete endpoint to when you're gonna let lifestyle be the initial treatment, and then talk about, do you need additional medical therapies? If you're a little more worried about somebody or their blood pressure is a little bit more on the high end, maybe you schedule the next follow up in 3 months. You have that flexibility, but we just don't want to miss the opportunity to actually treat them. And it does need treatment if it hasn't gotten to goal. Home blood pressures are the best blood pressures, I think, of them all. You're in your own setting. If you spend a few minutes teaching them how to take the blood pressure at home, I love when they bring in their blood pressure readings and then we can do something with them. And I think they feel empowered too. They're getting feedback like, why are my numbers all so high? And when we teach them what's normal, what's hypertension, I think that, that can change even the patient's thought about why they should be started on treatment. And I think that keeps them more conscientious. It makes them monitor their blood pressure and recognize that they are actually having elevated or stage one hypertension or stage two, whichever one it is, that they understand what's going on and why we're
Mhm.
having close follow up as well.
Yeah, great points. Very much the way I practice too. And of course, when those high risk patients were inspired by the SPRINT study, which showed that aggressive blood pressure control led to less cardiovascular events than a traditional, more lenient approach.
Michael, what do you do with your older patients?
That's a tricky one, but a great question because there's also added benefits of blood pressure control, like reduction of dementia, reduction of kidney disease, these things that are so relevant to older patients. But of course, we need to be worried about things like orthostatic hypotension and falls too. So if my patients are high functioning, I'm still treating my older patients pretty aggressively as far as blood pressure, but absolutely, like you said, they have to be measuring their blood pressure at home, reporting back any side effects. But I think we do a disservice if we say, well, just let your blood pressure go up because of your age. Now, of course, we need to be careful, but in general, I'm adhering to fairly consistent kind of blood pressure targets, regardless of age. Let's do one more topic on this medication front, which is the cardiometabolic therapies for weight management or obesity or for diabetes. Of course, these factor in nowadays to the primary prevention discussion too, particularly in the high risk patients. So, what do you think about this group, Martha?
I think this is where we have the most potential now to save lives. I think before we didn't have very many medications. We recognized these patients in our clinic, and the recommended treatment until recently really had been lifestyle. And again, we agree lifestyle is an important part of it. But now we have a lot of therapies that we can help people and sort of identifying that cardio kidney metabolic milieu. These are patients we all see all the time.
Mhm.
We see patients with a little bit of hypertension, and they have obesity, they might have abnormal liver function tests, maybe a little bit abnormal estimated GFR. We have therapies that can target all kinds of different things. And identifying these patients is a game changer. They have the excess weight, but they're also having consequences of that excess weight on other organ systems, whether it's cardiac, whether it's lipids, whether it's the liver, whether it's the kidneys. All of it is intertangled. We have these amazing drugs that help, first of all, from a weight loss standpoint, but that are also doing other things to almost every organ that is relatively speaking has been beneficial. Even things like SGLT2 inhibitors, MRAs, but even treating diabetes. If you're using these medications for diabetes or deciding to use an SGLT2 inhibitor, I do feel like this is part of our cardiology work to do. We have to be able to treat patients where most of us are internists first and cardiologists second. So I think there's a lot of work to do in that area. And I see these emergence of these cardio kidney metabolic clinics popping up across the country. So we just need to recognize that we now have therapies and we need to be screening for um, these risks. We should also be checking urine albumin creatinine ratio on patients that are at risk for chronic kidney disease. If they just have hypertension alone, they should be getting that at least assessed regularly. Suddenly you're realizing that they already do have disease starting, especially by the time a urine albumin creatinine ratio is elevated. That's the beginning of kidney dysfunction.
Yeah, such a good summary of where we stand from a cardiometabolic point of view. I do want to close with one quick discussion of the interdisciplinary care team in our prevention practice. Of course, we're cardiologists. We make some of these decisions, but we use our other members of the care team to deliver care for our patients, right? Whether that be people from our diet and behavioral kind of coaching side, our pharmacy team. So tell me, Martha, in your practice, how are you bringing together your team members to provide comprehensive care for these high risk patients?
Well, I think that is such an important point, and I think the team is really gonna make things more efficient. Whether you're an internist, family physician, or a preventive cardiologist, you're going to create a plan for the patient. And that might be the initial visit where we identify what needs to be done. But if you have a team that works with you, whether that is a dietitian, whether a pharmacist, whether it's a nurse, nurse practitioner, outlining these goals and being able to everybody to use their level of expertise at the highest level that can help patients. I had a very wonderful model in the past where I worked with teams of pharmacists. We'd create the plan on the initial visit, but often the follow up was with my pharmacy colleagues. And it was great. They knew we were a team, so the patient didn't feel abandoned. I think the other thing is thinking about our professional medical colleagues, our endocrinologists, our
Mhm.
nephrologists, our hepatologists, as well as preventive cardiologists. We're all in this together. And we need to discuss with our community, with other experts in the area, knowing when to send them, when you can collaborate. I think these are the important discussions. And that's why I like the cardio kidney metabolic teams that I'm seeing created, because I do think it can change
Uh-huh.
how people practice and the efficiency. I think ultimately a patient will get better care if we have close follow up, and that's not going to happen necessarily if you're saying, okay, well, you have to follow up with a physician only.
You did a great job of summarizing their role. This is a great discussion. We covered everything from when you make that decision about lifestyle versus pharmacologic interventions. Then we talked about lipid lowering therapy, LDL goals, aspirin, which is important in this space. Of course, choosing antihypertensives and blood pressure goals that make sense for your patient. And then considering cardiometabolic disease, the whole spectrum, cardio, kidney, metabolic spectrum for our patients, even in primary prevention, where we can make a big difference by intervening early. So I just want to say a special thank you to you, Martha. You're one of my heroes in the field. One of the best preventive cardiologists, former president of the American Society of Preventive Cardiology. So it's such an honor to have you on the podcast, and what a great discussion we had today.
Thank you, Michael, for having me.
And thank you again to our listeners for joining this podcast on preventive cardiology and the cardiac risk continuum. And please join us for the remainder of our series where we'll cover individual patient cases and how to approach particular high risk patient phenotypes that we see in preventive cardiology every day.